Hello, everyone, and happy Friday. I am Michael Steelman, Director of Alumni Career Management and Professional Networks for William & Mary. And it is my pleasure to welcome you to today's William & Mary Conversation and Connections, Health in Virginia. This event is the third in a series of events sponsored by Town Bank, bringing William & Mary leaders throughout Virginia together to discuss business challenges, partnerships, and collaborations. It has been a pleasure working with Town Bank on this initiative, and we are delighted to have William & Mary alumna and Town Bank's president of the Virginia Peninsula and Williamsburg area, Alexis Swan, as our moderator today and throughout this series. Before I turn things over to Alexis and our esteemed panel, I just have a few technology items to cover. Today's session is being recorded, and we will notify all registrants once that recording is available on wmalumni.com. Questions are welcome throughout the presentation, and our panelists will address as many questions as time will allow. Alexis will moderate the questions by you typing into the Q&A chat, Q&A feature, or the chat as well. Now, without further ado, it is my pleasure to introduce our panel and moderator. For the interest of time, I just will quickly introduce our panelists, and I'm sure their experiences and expertise will be incorporated into their remarks throughout the hour. First, we have Kevin Leslie, Executive Director of the Hampton Roads Biomedical Research Consortium. Kevin earned his BS and MS in biology from William & Mary and his PhD in Integrated Life Sciences from VCU. Next, we have Melinda Hancock, Chief Administrative Officer for Sentara Healthcare. Melinda received her BBA in accounting from William & Mary, as well as her MBA in Healthcare Administration and Management from the University of Phoenix. Next, we have David Warren, Chief Executive Officer of Tidewater Physicians Multi-Specialty Group, known as TPMG. David received his BBA in accounting as well from William & Mary School of Business, Mason School of Business. This terrific panel will be moderated by William & Mary alumna, MBA alumna Alexis Swan. And we really thank Alexis again for her leadership and support of this series that brings together our leaders throughout Virginia to discuss the business issues, the challenges, our partnerships and collaborations that we can do together. We look forward to today's conversation on health in Virginia. And now, Alexis, please take it away.
There we go. Good afternoon, everyone. So glad you all are able to join us today. It's my pleasure to be here, and I'm looking forward to this conversation. Town Bank is honored to sponsor the Conversations and Connections speaker series for the William & Mary Alumni Society community. We are so excited that and proud of the school, I should say my school, for the last couple of years of weathering some really tough and challenging times, but yet we're being creative in finding ways to continue to connect people and to have conversations of some really worthy topics that affect our community and our society as a whole. Town Bank believes in community. I hope each and every one of you know that. And as a proud sponsor, we wanted to make sure while we didn't have everything to do with the actual picking and choosing of everything with the speaker series, that we wanted these topics to be shared and communicated about so we could start dialogue and begin to find ways to provide solutions to some of the many issues and concerns and opportunities for our area. So I'm excited for some of the alum that are joining us today. And I know that there are quite a few that are out there in our community that are interested in this topic. And I'm excited to hear from the specialists that are here with us today. So I am going to get going and we're going to keep moving forward. I think one of the first things that I thought about when I was contacted about this particular topic is, I mean, everyone's been talking about healthcare, right? It's top of the world, probably more than you ever have seen in the news. And I think about COVID, I think about all the things that are going on, and it's been challenging. And just curious, what are we seeing about the state of the healthcare in Virginia in particular? What are some of the new and up and coming trends and possibly things that we have learned from COVID? So I want to start with Kevin, if I can.
Absolutely. Thanks, Alexis. So obviously, David and Melinda are also going to, come at this through their own lenses, and I would say I'm the least on the ground in terms of the physical delivery of care. But I think I can speak to both, my time at VCU too, from the beginning of this pandemic, and kind of what I saw there and the lessons learned piece as we've kind of looked at two different regions. And so obviously there have been massive disruptions, both positive on the technology side, staffing, public health guidance, all of the stuff that systems have had to navigate. And I think the few things that I would point to, first starting on the positive side, the remarkable adaptability and flexibility of these systems. When you think of health systems as behemoths, but then, in the first 3 months of the pandemic, see what you can actually pull off in that kind of wartime scenario. Not that that is desirable all the time, but it shows you that you can do that. I think when we look forward, being able to harness some of those positive aspects in terms of thinking about identifying a critical problem and then rapidly bringing folks together to solve it. I've seen that across the board. So that's actually been a very heartening thing. I think, one of the things that's been very interesting is just, in terms of care delivery, you have to actually get people to act in the first place, to seek care or follow guidance. And, public health messaging has really been put to the test. When you have so many parallel sources from, the city to your doctor, to the health department, to the CDC, all issuing things simultaneously as the science is evolving, and then trying to make sure that people can even understand it. I think there have been a lot of different strategies that have been put to the test, but one of the things that I think has emerged, from what I've seen, particularly on the research side, is, in keeping community leaders engaged, particularly for at-risk communities, has been fundamental into really moving the needle in areas where you really need it to move. And so I think going forward, that's going to be something that is really important to continue to strengthen. It's something our organization is really focused on, both for research and just the community partnership element. And then I know David and Melinda will probably speak to the telehealth bit, but I think it's been really fascinating to see. It's not like it's overtaken everything. It's certainly been a really powerful thing to augment the delivery of care. But we've also seen, in places where it might be needed most, particularly in rural areas, the disparities for deploying that. And I know we may talk about that a bit more later, but just the lack of access to broadband and technology to tap into that is something where we're kind of getting this digital divide. So those are the three big ones from my side.
Great, and they're all really important. David, I'll go to you next. What are you seeing as some of the trends or areas of opportunity for us to discuss, given what we've experienced in the last couple of years?
Well, for us, it was definitely the technology side. So when, we have kind of a timeline that we wrote down during the pandemic, because as a professional service corporation, we don't have endowments or a lot of a slush fund to go to. And if we can't go to work, our model grinds to a halt. So having to stay up and the payers agreeing to pay for virtual visits, very, very helpful. And I think the thing that was the most, because the pandemic was it was horrible, because, we had to look at staffing and make some difficult decisions. But very quickly, some of our vendors, banks were there to try to help. And it was amazing at how the business community kind of chipped in and tried to help groups like ours stay in business. And with that, we were able to purchase a bunch of PPE, and actually we got some donated by groups like Centera, and allowed us to stay open. And we were testing people in the parking lots, had drive-through vaccines for kids and things like that. So we fought hard to stay open for people who felt like they could get out and seek care. And our surgeons had a tough time, because the hospitals had to divert elective cases because they were dealing with the pandemic. So their elective stuff, so they're kind of sitting on their hands waiting. The hospitals didn't want to do that because it hurts them financially too. So in my mind, just watching kind of the business community, banks, landlords, all trying to have relief, I felt like that was a very, very positive thing that we said. But technology, I don't think is going to leave us. We're still doing virtual visits, and and I think our patients expect that.
Yeah, I agree with you. I can't think of a more prouder time it was for me to work in the banking industry than it was during that time when we were putting in 12, 14, 20-hour days. But it did feel good that we were coming together as a community, much like what we're trying to do in this conversation, and just kind of start the dialogue and begin to tackle some of these tough things that they're not easy to solve. So I appreciate you all's comments. Melinda, what would you add to that conversation?
Well, I think, so I think to the first part of your question, a little state of the state, where we are right now, so we're from a hospitalizations perspective. So that the curve, we've kind of tipped over this fifth curve or this fifth surge. This was the biggest one we've seen. So Omicron, far and away the largest surge we've seen, and but it is falling quickly. However, when you look at the number of hospitalizations today, is just under where we were this time last year. So it's still significant. So most of the hospitals in the state, if not all the hospitals in the state, are still struggling. So I think it's important to understand that while we are coming down off this curve, everybody's still really just trying to make this, get through this at this point. Staffing shortages, just unprecedented numbers still coming to the ED. And in some cases coming from mild or asymptomatic. And so I think that's one challenge we continue to have is where's the right place to go for testing. So I know a lot of hospitals are even teaming up together, which has been a really cool thing from this, watching everybody just put down the competition and say, how do we do the right things for everybody? So where's the right place to get tests? Where's the right place to get information? So we can really keep the sites of care for the right level of acuity. We did make the difficult decision in January to postpone all of our electives again, given where we were from a patient load perspective. But that also allowed us, to David's point, to reassign people. So where do we need the team members? And so really be able to backfill the staffing needs that we had. So we have resumed our non-emergent surgeries now, but it's a challenge. It's all impacted by the blood shortages that I'm sure you're seeing all over. I think there's a lot of pleas from a lot of the localities. So if anybody's looking for something to do when they leave this webinar, go give. We need donate blood, please. But also staffing capacities and just the true volume and capacities of our EDs and our hospitals right now. But then, what have we learned from this? There's so much. I've said this before. I wish I had someone sitting on my shoulder as a ghostwriter the last 2 years to capture just some of the amazing conversations, the ability to make decisions, in a split second, the coming together with common purpose for the communities. Some of the examples that Kevin and David have already given, 100% agree with David on technology. What we're seeing, though, is technology is now advancing faster than I know I've seen it ever in healthcare. So how do we keep up with it? And where's that leading? And it's all into a consumer centricity, which is where it should be. Patient and member at the center of all of what we're doing. So it's really launched the acceleration of technology, which is really appropriate. And how do we deploy it? So I think when we think back on all of this, it's made us rethink supply chain. It's made us rethink operations. How do we, the word nimble, we never used with healthcare, to Kevin's point earlier. So I would add the word nimble too, because we've learned now to have flex up, flex back. So now with 5 surges of COVID, we've learned we've always known our business, but now we really know how to be nimble, how to flex up, flex back. But we've also learned how to, things we weren't doing well, nothing like a crisis, put that big old flashlight in right on it.
Mm-hmm.
But we've also learned what we're not doing well. And we've got to make sure that we are taking care of that. So I know we'll talk more about that later, but access to care, equitable healthcare, there's so much more that I think we've all committed to doing better, more, but how do we make sure we're accelerating that as well?
I think you brought up a really good point. My next conversation was going to lead right into health equity. So I think it's an interesting topic. And I think it's been talked about probably more than ever when we're talking about, why is it bubbling up? And I think what we're learning is there's power in collaboration, but we also learned what a community really is. What affects one affects everyone else. And for a while there, I kind of feel like we all lived in our little bubbles until we realized, oh no, what happens to me can affect someone else. And we had to learn the power of community. And that, I think, brought to light a lot of the things that I want to hear you talk about, which is health equity, and what does that mean? Somebody at work stopped me today and said, what does that mean? What does health equity mean? And why are people still talking about it? But, I think about technology, I think about rural areas, I think about people who are poor or, homeless. Everyone still needs care. So, I'll start with you, Kevin. And health equity is important, particularly in Hampton Roads. And what are we doing about it, or what are your thoughts about health equity?
Sure. So selfishly, this is part of my organization's mission. So we're a consortium of ODU, Sentara, EVMS, Norfolk State, and one of the pillars is to address regional health disparities, but also export that. And I think, to your point about what is health equity, what are health disparities, it's making sure everybody has the same opportunity to be as healthy as they possibly can. But when you break down, take that into a few smaller pieces so that people, I think, can grasp that. There's the access piece, right? Can you physically get to the place you need to go for care? Can you be insured? Can you access specialty care when you need it? But then there's also quality of care elements too, right? Are you receiving the same kind of care? Is it, to the, same level of efficacy? Is the care coordination happening? All that kind of stuff. And so when you look at different, races and ethnicities, different income levels, that's where disparities in these areas really start to emerge. And I think what's very interesting, so annually, Department of Health and Human Services releases a report on health disparities for the country. And the good news for Virginia as a state is we're in the top quartile in terms of having fewer disparities at large. However, the real story is kind of at the neighborhood level, even from a Hampton Roads perspective, where we have disparities in cancer and diabetes and low birth weights and pretty significant areas where we are behind in what might not seem like large percentages. That's because we're averaging a lot of those numbers as a region, but then when you actually look at specific census tracts, it's wildly different. And so I think there are a couple pieces here in terms of addressing it. There are certainly there are limitations to what hospitals can do behind their doors to improve some of these things. And I think it's important to distinguish that. You can only deliver so much care if you can't get somebody there or get them insured. And I think the other piece is actually understanding the source of a lot of these problems and also the prioritization of how you can address them. So part of our organization's focus from the research perspective is the community element that I mentioned, which I think is critical to actually moving that stuff forward. And the technical term is community-based participatory research, but you have people in the communities that you're trying to help driving the conversation and priority, because you can come in and say, oh, look, these numbers on cancer, diabetes are really terrible. We should do something about that. But they might say, well, the mental health crisis and gun violence are far ahead of that in terms of actually talking about addressing any of those other things. And so I think being able to have a complete picture and community engagement is sort of step one in, fully understanding those, but then also developing and deploying solutions with that community partnership along the way. And then the second piece, I think, is using all of these, research and technological tools that we have at our disposal, not just to understand, but to model and address those. Because I think, for a lot of people, it's like, all right, we're going to silo this and say we want to just address diabetes. But in most cases, that's highly complex and could involve, an access to care problem and transportation. It could involve a policy. So these are really big problems, which is why they're still around. There's a lot of historical basis for them. And I think the most heartening thing from my side is that, particularly for the Hampton Roads region, there's a pretty big shift in terms of regional collaboration from the city standpoint and the institutional standpoint. Just because I think there's the pandemic, as Melinda said, it kind of shines a spotlight on everything, because the things that were broken don't magically get better in the middle, they get worse. So yeah, I think from my side, there's certainly a lot of problems to address, but I feel like we're in a really good position to move that forward and then export that across the state, right? We talked about this digital divide for rural and urban, but I think that that's not just for telehealth, it's for a lot of other elements of just delivery of care. So
Yeah.
yeah, I'll probably leave it there.
Yeah. Good things. I love what you said about, it is shining the light on things that we all are having to have conversations about. It's kind of the beauty of today. David, what do you think about the term health equity, and how is your company addressing that?
Well, unlike Melinda and Kevin's company, we're for profit. TPMG is, it's owned by physicians, and so we have shareholders that we have to report to. But that being said, we have a diverse patient panel, probably not as much Medicaid as as we could. But one of the areas that we're focused on in order to try to help with that, first, we're trying to work with the Medicaid plans. And I think if the state did something a little bit more creative, where kind of like Medicare Advantage, that might help with things as far as financing the access, if you will. But one of the things that we're working on now is kind of a collaboration in Hampton, where we feel that, and the new president of the Careplex there feels that we need to do a better job of pre and postnatal care in that market. So we're working with them to develop a midwifery program which can better serve that community. And that comes with a centering program that we already have that is really, we do a lot of Medicaid work in the OB field. So that's kind of the area where we've kind of got a little sweet spot that we can work on. So for us, it's a matter of getting people the pre and postnatal care that they need when they may not have the support system that a lot of other people's do. So that's just one instance of something. And I think we're very interested, as we learn more about the Medicaid world and how we might influence that, of being, trying to be part of the solution when it hadn't really been part of our core business in the past.
Yeah. I love to hear that story. The power of collaboration is really important, because what we know is not one entity, person, or place is going to kind of tackle this, and it's going to take us working together. So I love that story. How about you, Melinda? How would you address the term health equity and ways that you all are thinking about it?
So 100% agree with Kevin's definition. And when you think about the mission of Sentara, we improve health every day. But that's not applies to one group or one community or one neighborhood. That's to everyone. We are, as a community asset, that is our mission. So how do we then deploy that, and how do we do continue to work on that, because that job will never be done. So it's one of the things that attracted me, to be honest with you, to Sentara, is that mission. During COVID, for example, we partnered with faith-based organizations and did over half a million COVID tests, nearly over 200,000 vaccines, really focused in more the vulnerable populations and areas of Hampton Roads and our other markets. We held over 550 vaccine clinics, registered more than 30,000 volunteer hours. But how do we continue to do more and more? We really focus on the social determinants of health. And so for those of you who don't live in that world on a regular basis, it's kind of the overall thought of your overall health is influenced by more than just your medical care. So by and large, the average numbers are your direct health care accounts for 20% of your health. The rest, where you live, learn, work, play, even your genetics, account for 80%. And so how do we're good at the 20%, and we know how to measure the 20%, but how do we work on the 80%? And so we're really dedicated to some of the things that we've been working on and deploying throughout the community on that 80%. Nutritious foods, education, safe and affordable housing, stable job opportunities, workforce development. All of that is so important to us. We've created a health equity department. Iris Lundy and Dr. Keith Newby are leading that. We work really hard. We're an integrated system. What does that mean? We've got the provider side with our 12 hospitals and multiple access points. And then we also have our health plans. We have 950 lives within our health plans, but 74% of those are Medicaid. So over 700 of that 950 lives are Medicaid lives. And so how do we continue to focus on the social determinants of health? And how do we partner with the provider and the health plan side to lower the cost of care and improve the quality? We partner with a lot of the faith-based organizations throughout our community. We also started the Sentara Healthier Communities Fund, $50 million in 2021 that we dedicated to this. We're working on new models of care. We're rolling out a new mobile clinic that will provide access to preventative care services in under-resourced neighborhoods. Instead of you coming to us, we're going to come to you, because access is different to every single person. How I define access to me is going to be different to how someone else defines access to them. So how do we make sure that we're changing how we think about the delivery of care to meet the patient, not where they are, but where they want to be? Because if we can make healthcare simple, it will actually raise all ships. So that's really what we're working on. And where we're going next is behavioral health. Behavioral health is so important, and we've got to make sure that's integrated in absolutely every single thing that we do. So really trying to bring all this together is really how we're working to make sure that we're improving lives every day.
Great comments. I'm trying to answer some of the questions that are popping in, and since you're speaking from the hospital state of things, we had a question from one of the attendees saying that Governor Northam, before he left office, issued a 30-day emergency order last month allowing for increased hospital bed capacity and relaxing some qualifications. They were curious if it helped, if it affected you at all, and will the shortage of hospital beds now, should it be easier to seek approval for increased capacity so that it'll help through some of these spikes and pandemics going forward?
Yes, it helped a lot. So really very appreciative of the support of the outgoing governor, and also Youngkin as well, to really help support the hospitals during these capacity issues that we've been having. The emergency order not only helps with the capacity issues as mentioned in the comments, but also helps us with staffing. It helps relax licensing from other states and things like that. So it really does, it was a big benefit to us. This was similar to what was in place at the beginning of the pandemic, which was a big benefit to us. It just gives us a lot more flexibility to make sure that we can be as flexible as possible to meet the needs of the patients.
Mm-hmm. Okay. You brought up before mental health, and I know you mentioned that your health care is 20% going to see the doctor and that kind of stuff, and 80% environment, community, other things like that. Mental health care has been topic of a lot of things lately, and I'm kind of curious what you all are seeing. It's a major issue. We're seeing it affecting others, right? We're seeing it affect all walks of life, not necessarily any particular demographic right now. It's just a heavy world we're living in. I'm just curious how those issues are affecting healthcare, your organization in particular. I'm going to go back to you, Melinda, because you brought it up, and then I'll make my way back around to David and Kevin.
Sure. So as you know, Sentara is throughout the Commonwealth. And so it's something that we're looking at, yes, in Hampton Roads, but also in all of our markets. And it's, Virginia is just chronically short of behavioral health resources, inpatient beds, outpatient access, you name it. And throughout the pandemic, it's just getting worse. I think we all have probably personal stories as well that we can share of just the challenge that we have within the Commonwealth. So I think we have actually convened a system behavioral health tactical operations committee, and it's a multidisciplinary group of leaders from across all of our different divisions to make sure that we can focus on this and put dedicated resources. We're in the process of finalizing our strategic plan as well for the next 3 years, and behavioral health is a key focus of what we are doing from an acute care perspective, but also from an ambulatory as well. So making sure that we're infusing behavioral health in all that we are doing. So we're going to be making some short-term and long-term changes to improve responsiveness and also the level of care. So we'll be looking at virtual assessments, telehealth, we talked about that earlier. How do we infuse it again to where the patients need it? Because we're so used in healthcare of come to us. No, we have to make sure we're going to our patients. That's what that whole centricity is. It's not about waiting for you to come to us, because at that point, sometimes it's much more challenging. So we need to make sure that we are where the patients are. And so we are looking at a pilot program right now, establishing a community access points in Virginia Beach to provide behavioral health patients an alternative to EDs when they need support, but not a hospitalization. So those are the type things that we're going to be rolling out, and really also working with the Commonwealth and seeing how else can we support, convene, and partner.
Yeah. How about your thoughts, David?
Yeah, I completely agree with Melinda, and I think there's a question in the Q&A box about just the shortage of physicians, and I think psychiatrists are among the most shortage that we have. And not only that, there's a large percentage of practicing psychiatrists that are close to retirement age. So at TPMG, we do have a behavioral health division, and we were trying to figure out how to maximize that, because with one psychiatrist, it's very difficult to get everybody in, to see him, or a nurse practitioner that reports to him. So we had to come up with a strategy to try to have it to work on access. So we're actually piloting a collaborative care model, which is primary care based. So the primary care physician gets a patient in, and we can run a registry of all of our patients who have been diagnosed with anxiety or depression, let's say, and the physicians can pick and choose which ones to enter the collaborative care model, but it stays at the primary care level. So we have a care manager that will be there that will be specifically for behavioral health, either embedded in the practice or remote now, because we can do more virtually. So the technology piece has really helped with this. So that person has access directly with the primary care office and the staff, intervenes with the patient, and then has a direct reporting line to the psychiatrist. So the psychiatrist's time can be used to really help with complex medical management and things like that. But there's a check-in period with the patient each month. And we had a shareholder meeting last night, and our psychiatrist, Dr. Richmond, presented this. And we had one of our primary care physicians that, also presented with him and said his patients love it, because it removes the stigma of saying, oh, I'm referring to the psychiatrist. It's no, I'm managing your care with my behavioral health professional here. And we have the psychiatrist basically on speed dial to be able to help with anything that you need. So for us, we're hoping that access is done differently. And, I hate to, every time I talk, it's, there's always money involved. So there are some billing codes that allow us to do this and have touch points with these patients, and the payers will pay it because they see the benefit of having people at least have some access, which is better than nothing. And another thing that we're doing kind of addresses Melinda's comment of, we're trying to be available to hospitals, to their ERs, and have our behavioral health team maybe before and after hours touch base with the ER docs on patients that are there. So can we get them out to the outpatient or a step down facility and not have to tie up a bed in the hospital when they're not designed for mental health? Those are separate. I think they're separately certified beds. So I think that's the biggest challenge that we see in healthcare today is the mental health piece. And we don't have the answer. We're trying, and hopefully this new collaborative care model will work. But we've got a few months to trial it and see how it can go.
Great. How about you, Kevin? How would you answer that question?
A couple different things. This one's pretty, close for me personally for two different populations. So two of my sisters are in healthcare. One's an NP for pediatric transplant. The other was in, palliative care and oncology. And one ended up just leaving in the middle of the pandemic because the mental health stress for providers, particularly if you're, a young mom, are just, it's something that we just don't talk about as much. And then even, for the one who stayed as a nurse practitioner, the stress from both the staffing side and everything else, I think is something that's finally starting to get recognized, not just in terms of operations, but realizing that there's a finite supply of human beings who can perform these jobs. And we really need to make sure that people are being taken care of. So I think that has gotten a new kind of light shined on it, and so I'm hopeful. Within each health system, there have been some individualized efforts to improve that, not just from a cultural perspective and change to, you don't just have to power through this, but we actually are going to accommodate and provide resources. And then I think from the other side, the pediatric mental health question, I think, is really interesting. So, this was the personal connection. Again, my wife is a psychologist and focuses on particularly kids with autism spectrum disorders, and the wait list to see anybody are 1 to 2 years long. And when you talk about autism and early intervention, that's critical time. So it's not just hospital beds when we think about being able to address things during a crisis, but just the actual capacity for this entire pipeline that is pretty challenged. And so there are a couple of things that I think are really helpful. So the telehealth piece, again, is really amazing for being able to expand both access and really get a higher volume in the door. But again, we have that digital divide piece. So I think the investments, Virginia actually does a pretty good job on the broadband front and is improving. So I think that's going to be a game changer for the state in terms of access there. But then again, even with inpatient beds, right, you may have huge waiting periods that go beyond that crisis and your window of opportunity. And so, regionally, we actually have great news on CHKD's front, putting up this, 14-story inpatient facility with, 60 beds dedicated exclusively to pediatric mental health and bringing in a lot of practitioners there. So I think that capacity is slowly building on sort of the physical bed front, but then the just delivery of care piece, when you think about a fifth of kids have a diagnosable, mental illness, but only 25% are actually going to get care. It's pretty startling. So, and the Surgeon General has echoed as much just in terms of the youth, mental health crisis. So I think the pandemic, again, has shown a light on things that were really problematic, but Virginia in particular is, I think, positioned better than most to tackle that.
It's great. Yeah, I think of all the things you guys are bringing up. It makes me concerned about shortages. Clinician shortages and doctor shortages. On one end, I have a daughter who's in med school, so I'm excited because that means I hope she'll have a job when she finishes without an issue. But I also think about it's tough even as a medical student to the mental stress of kind of making it through. And so I can't imagine what it's like being a professional in that field. What are your concerns about some of these shortages, and what can we do, or what can schools do to ensure that we continue to have physicians and nurses in our system to address these problems? Who wants to go there? Who wants to be the bold one to start on? David, how about that?
First off, please give your daughter my email address. So when she's looking for a position, we'd be happy to talk to her, particularly if you want her back in Hampton Roads. So, but that's a huge challenge for us. It's huge. I mean, right now we're having to almost redesign our model because it's hard for us to get physicians to fill all the open positions that we have. And I think the health systems here are no different. And we're fortunate in that we live in a great part of the country. So there are reasons that people would want to move to Hampton Roads or Virginia in general, that, as opposed to a colder, harsher climate or whatever. So, but even that being said, there's a dearth of particularly primary care. That's our bread and butter that we have, but we're also recruiting surgeons, and it's tough to find the right people. So right now, I would say the solution that we have is we're using physician extenders more and more. And I see that as being a model that will be developed going forward. But I think it's, maybe there's something the state could do about, like with student loan debt or stuff like that, that would make Virginia a more attractive place for people to come. Right now, I don't know. I mean, I think we're sitting on, billions of dollars. Maybe that could be something that the state could invest in. I think that's periodically been something that's been available, but it hasn't been funded recently. So, but I don't know. But I think unless schools start cranking out more doctors, I really don't, I don't see a really good solution for this going forward.
I do sit on a board for a university, and I know that we've noticed applications are higher than they've ever been. So I do think that the generation that wants to do good for the public good, you're seeing an uptick. But I also worry that once they get in the field, will we keep them long, given the stress and the mental drain it is to work in the healthcare industries? Uh, Melinda, what would you say on that topic about encouraging more to get in the workforce, and how, you know, how you're dealing with those shortages?
But so, yeah, workforce is a huge part. I mentioned we're in the getting ready to roll out a new strategic plan, and workforce is a huge component of it. I mean, I think it has to do with all elements of our workforce. So I think there's a bunch of different ways that we're addressing it. First of all, to David's point, the pipeline. We've got to be creative in how we think about the pipeline. So, we're also thinking, how do we go earlier and earlier into schools and start? Right now, there's some great programs that a lot of health systems in Virginia have. We have some too here, of talking to, high schoolers and things like that, but we may need to go deeper than that. How do we get people engaged and involved in healthcare? I know when I've always wanted to be in healthcare. And I thought I knew what I wanted to do, but I couldn't get through chemistry. So I knew I couldn't be a clinician. So I was bummed. And, but that's when but I was good in math. And that's when I discovered there's every job in healthcare. And so how do we start really thinking through how we expose people earlier and earlier and get people excited about all the different things that are in healthcare? I think there's also a lot of redesigning of care models, and how do we think differently about the workforce that we have and the workforce that we need to have, and skilling people up and working at top of license. And we've talked about it a lot, but how do we actually engage it and do it? And then, to the earlier conversation, use technology to enable. And so it's really important that all of this is coming together right now. And it's a great time to be in healthcare, but I also know it's a very frustrating time to be in healthcare. So how do we really envision a future that takes advantage of the skill sets and gets people excited again to really be be on this trajectory of where we should be in healthcare, which again puts the patient at the center.
Yeah. I think the good news about all of this is now we recognize that we have to take care of the whole being, right? It's not just offering the best job with the best benefit. It's taking care of their work-life balance and their mental capacity. And so I'm encouraged that it's out there, because it's always been there. It just hadn't been discussed. So I'm encouraged that you guys are thinking about programs in which you are taking care of the whole employee and the whole staff, and hopefully encouraging others to do the same. Kevin, what are your comments about the shortage, and from your standpoint, how do we continue to grow opportunities or ways to encourage people to enter the field?
So other than the stuff that we've covered, I mean, I think there are a few systemic things, but also a few, on kind of the negative side, but also some positives on the moving forward side. So obviously, we also have a system where residency spots are restricted, right? Your daughter will shortly see, and that does limit our capacity to move doctors out. So we have kind of there's the cultural piece of it being a really hard job, regardless of where you sit, but also that bottleneck in providing that next step in training, which is kind of a national level problem, not just about recruitment. But I think, to Melinda's point, this sort of re-envisioning a little bit of what being a provider can be like, and the technological augmentation we've talked about, not just telehealth, because I think that's really easy to default to, but some of the devices that enable you to get the information and the readings you need just from within your home, that then can be move forward. So it's again changing the game there, but also thinking about coordination of care too. As technology has improved that, we have fewer people slipping through the cracks, fewer mistakes, and I think that broader improvement too means you can do with slightly fewer workers than you might have needed in the past. So I think there's a lot moving in the positive direction, but there are some systemic pieces, particularly on the cultural and burnout side, right, that I think will eventually kind of make their way through the system, but it's a pretty big system. So.
I think you're muted.
Oops, sorry. I said I'm continue to read the questions and trying to multitask as they come through. Um, we have outlined some real challenges. How can industry partners support your efforts toward better solutions in the areas discussed? Staffing, technology, supply chain, education, and are there some innovative and novel ways that industry leaders can contribute? So I think banking, right? I think we've learned more about healthcare lately than we've ever had, and I was proud to be a part of that with the PPP program. But it's getting us to really get into, especially when we're banking or serving doctors or practices, to learn more about some of the challenges and struggles and do our best. And then on our foundation side, making sure that we're giving back charitably. But those are the ways that I think we're thinking of it. David, what are your comments about other industry leaders and how they can help support the healthcare industry?
I think for us, because we just kind of have this one niche as providers into the thing, and we do own a little bit of bricks and mortar for the stuff that we do as far as imaging and some of the other advanced stuff do. And I think a lot of the businesses are moving out of the hospitals. But I think that if we can do some integrative stuff with both with vendors that are in our health, our industry, plus anyone who's outside, on how to better serve particularly companies that provide health insurance. So like if there are some innovative ways that we can do to keep their employees healthier and their costs lower, that's what we want to try to do. But we have to be careful, because the more that we push to try to be that one solution, the more you could harm other vendors or whatever they are in the market. And it could be a short-term win, but a long-term, if hospitals go out of business, that's not helpful for anybody. So for us, it's more about how do we bring all of these, and we're seeing that there are some companies, particularly vendors that offer like implants of certain type things, may want to help independent groups develop outpatient standalone facilities to provide care there. I mean, they have a vested interest in doing that. So I think you'll see more capital coming into our industry from that standpoint. But that's just kind of the general idea I have on thoughts about collaboration across service lines.
Good ones. How about you, Kevin? What is your thought on that? What are the innovative ways that other industries can get involved and support the healthcare concerns?
Sure. So again, selfishly from my organizational perspective, innovation is a big part of thinking about how to move stuff forward quickly, and that's a really uncomfortable process for a lot of larger organizations in particular. And I think one of the things you see, particularly on the academic side, is that often people will say, I have this wonderful solution, we just need to find a thing to use it for. When in reality, it's completely backwards, and you should be starting with, look, here is this big problem. So let's innovate around that and come together. And so I think what I mean by having them participate in that process, there's obviously the standard sort of financial support and that kind of thing, but we've already initiated a lot of direct industry partnerships when we talk about 5G Internet of Medical Things, and particularly on the medical device development side. We're standing up resources that enable people to not just come together and play in the test bed, but then and prototype and develop, but then also be able to deploy those. So I think being more comfortable with playing with both the academic and the healthcare sides in active development of technologies, but then I think the other two elements there are community support in an indirect way. We've talked about this sort of broader holistic nature of providing care and health equity. And so much of that isn't centered around the direct provision of medical care. It's providing an environment that allows people to be healthy. And so I think thinking about engaging in some of those programs that are slightly more indirect is really helpful. And then the last thing I would say is, particularly on the policy side, a lot of what we're talking about, is this combination of, a potentially physical solution. Maybe it's a funding thing, but a lot of times there are policies locally and otherwise that can actually steer stuff in the right direction for the communities that we're talking about. So yeah, I think being able to contribute their expertise in those realms, right? I'm focused on connecting as many people as we can to have those conversations. And most of them have been really uncomfortable, but we've actually gotten a lot further than I expected. So yeah, just not being afraid to get in the mud a little bit on some of those and play slightly more indirect roles than they might be used to.
Yeah. Melinda, I want you to share a little bit about that too, but I also had a couple of questions in here since you brought up policy about CON laws and should they be changed to allow more access and competition. It's curious, when I think of healthcare, most people go straight to the large healthcare systems, and I know it's a lot of tough priorities, and we had quite a few specific questions about how Sentara, and I didn't want to go down in a hole for that particular company. I'm trying to keep it on a big picture conversation, but address your thoughts about kind of what we're talking about and also ways we can help as an industry, what you think about some of the CON laws that have been discussed.
Sure. One of my responsibilities in Sentara is supply chain. So I would be, I feel like I must mention supply chain. So I think what's been truly amazing, back to a lesson learned to bring us all the way back to the beginning of this panel, is the amazing shifting and pivoting that a lot of companies in Virginia did to help the healthcare industry out at the beginning of the pandemic. So many companies just changed what they were manufacturing, what they were doing to really help out the healthcare industry. And so how do we continue to work to change our raw materials, domesticate more of our supply chain, make our supply chain much more dependable. It's really changed supply chain for the healthcare industry in the last 2 years, and it's going to continue to change. So we're doing a whole lot more demand forecasting and things like that. But how do we also just think about supply chain in general? I think that necessarily involves other industries. And so I think that's one way that we can all collaborate because everybody's dealing with supply chain issues. So we're kind of all in this one together. So how do we all think differently about how we address and do things differently with supply chain? So I think that's one thing I felt like I just had to get out there. CON. So it's CON laws. First of all, CON falls under the Department of Health. There's a reason for that. So I think that's an important thing to understand, that because it is about fundamentally quality of care. And so that's why the jurisdiction is under the Department of Health. But that being said, CON laws, like any other law, needs updating and adjusting as dynamics change. Healthcare, as we've talked about throughout this panel, is rapidly changing. So I think it's going to be important that we continue to adapt the CON laws for how we're doing business in the Commonwealth for healthcare. There's a polarity between competition and delivering needed services to all. So I think it's going to be important how we adjust those COPN laws to make sure that we are addressing that polarity. I do think they do need to be adjusted, but how they get adjusted, I think is going to be an important conversation. I think you're on mute.
Thank you for tackling that tough topic. I know that is a topic of conversation for a lot of people now, and it kind of goes back to kind of Kevin's last comments. It's about us as citizens being involved and paying attention to policy and things that you don't think matter. And it just reminds me of how important it is that we all are a part of a big community. Another comment someone put out there is, why not open more health clinics and senior centers or local community centers, or even side by side with local nonprofit organizations that assist them, aging population in the country and limited mobility for this segment. I think this is something that healthcare professionals need to work on, and it's important for minorities and lower income people. I think that's a great comment, Ms. Abigail. Would you guys have anything you'd like to add to that comment?
I might just jump into echo something Melinda said a little earlier in terms of the development of some of those centers being underway, but also just regionally, the ones that I'm aware of pop-up clinics are essentially taking that form, right, and trying to be as nimble as they can be to serve the exact areas that they need to be in, but co-opting spaces that are already being used for sort of community centricity, and jumping in there for 1 or 2 days a week, and combined with the mobile facilities that Melinda has mentioned, which I know are kind of deployed throughout the Centera system, and CHKD has them too. I think you're trying to figure out how you get the best coverage with the most efficacy, right? And so I think there's been a movement away from adding too many brick and mortar locations, but really trying to understand how you flex with the needs of the communities, particularly depending on whether you're talking about dental care or preventative services. And so, yeah, I've been excited just on the ODU side to see what they've put up across facilities in Virginia Beach and otherwise, and the Eastern Shore. But yeah, I don't know, Melinda, if you want to add to that or contradict it. That's just what I've seen in my time here.
I agree completely with her comments. And I think, back to one of the other comments too, is also the staffing. So I think that's what we're also weighing but we absolutely need to put clinics to my other comments, where the care needs to be delivered. So matching up, again, definition of access. So not where we think the clinics need to be and where they're easy for us. We've done that for too long, where the clinics need to be. So it's matching all of that up. Completely 100% agree.
Yeah. David, what is your thoughts on that? I wanted to make sure I gave everybody a chance to weigh in. I know Town in particular, we like to support a lot of nonprofit agencies that are doing more creative things to help support the healthcare systems and, free healthcare systems, clinics and things like that. But what's your thoughts on what more community members can do to support?
I think the healthcare industry in general can be a little bit arrogant when it comes to these kind of issues, because if we don't actively try to solve a problem like this, someone's going to solve it for us.
Mm-hmm.
So whether it's Walgreens or, that's why we're seeing so much competition, because there's an access issue already. So if you go into an area that, is an extreme access issue, someone's going to figure it out and solve the problem. So if the infrastructure that we have, that Centera or ODU has, is going to be effective, I think they're going to have to be more proactive in how we deal with that. That's just because somebody will figure it out, and I think that I would rather use some of the innovation money that Kevin was talking about to really focus on those particular areas. I remember I went to a VHHA conference in Richmond, and there was like a lot of first responders there, because the topic was going to be access. And they're like, what do we do with these people when we get them? Where do we take them? And I think the community is looking for ways to better service, people who need healthcare. So I think would be a great area to really focus on for some of the work. And I'm sure Kevin is doing that. And I hope it's successful. And if, that I kind of like when you pull back to what your group is, like I said, the midwifery program can be expanded out to do some other stuff within a community as well. I know there's some federal clinics that are in certain areas, and maybe coordinating with them to make sure that so it's not like a competition, and put these clinics where they're supposed to be. I think Melinda's absolutely right. A lot of times we run demographics like we're Home Depot or something, and we need to put the clinic where all these people are going to come. Well, is the real mission to drive profit in that entity, or is it to serve a community? So there's got to be some kind of collaboration between public, private, in my opinion, that will solve that.
Agreed.
I think the only other thing I might add in there is, something we didn't talk about in the disparities piece, which is diversity just within the physician workforce too. And that there's a lot of data, around disparities that says people in a lot of cases won't seek care unless the physicians or providers they're seeking care from look like them. And I think that's, something that we've seen, there are startups right now going through, the local ecosystem that are focused on exactly that. But I think that's something that's starting to gain a little bit more traction, but just one more piece of this puzzle, both in terms of the workforce at large, but also efficacy of, deploying what we're talking about. So.
Yeah, all good points. I've got an interesting one from Ted, he says, now that William and Mary's rector of the Board of Visitors, John or Lytle, I'm not sure if I'm saying it correctly, is the new Virginia Secretary of Health and Human Services, what advice would you give him now? Well, that's a big one. I think we've talked a lot about ways that we all think the community can support, but I think of things that we should share with him about things that are priorities, right? Because there's so many things to tackle out there, and things that we need to bring to light, things that should be a priority. So he's getting a voice from many different points of the spectrum. But David, what advice would you give him as a leader?
Loan forgiveness for doctors coming to the area and get rid of the certificate of need.
Yeah.
I'm just kidding.
How about you, Kevin?
Yeah, that is a tough one. I think other than what we've already covered, just the broader coordination of Virginia as a state. We've talked a lot about Hampton Roads, but I think regionally we're still kind of siloed, both in terms of the innovation piece, but also delivery of care, and everybody kind of having their territories system wide. And I think particularly in a situation like the pandemic, like we were just messaging and otherwise, it was a tough set of lessons. But I think if we can move towards that direction, that would only be beneficial. So, that's broad, but
yeah, no, I get it. How about you, Melinda?
We can send them a recording of this panel. So I think it's number one. Number two, I think in line with some of Kevin's thoughts is, let's not lose the last 2 years. We've learned so much, and we did some great things, and we also have some lessons learned. So how do we, it's almost like we need to go away for 2 days and do a massive debrief. Mm-hmm. What went well? What can we do better? We may or may not have to deal with this again, and in all of our careers. And but how do we gather up and say, okay, here's what we need to do again, and here's what we don't need to do again, and really learn from this, because there's just some beautiful, bright, shining moments that we don't want to lose track of. And there's a lot of innovation and learnings that we want to capture. And there's a lot of, we don't want to do that again. So I think that would be my advice.
Yeah, I think all of what you brought up have been good topics of conversation. And I think in a perfect world, we'd all do everything right? But unfortunately, sometimes what we learn is good intentions don't always come out the best way. And I think health systems have evolved like that, whereas we thought we were doing something good here and realized it had a negative effect to another group of people. And I tend to be an eternal optimist that people will learn from these situations and continue to grow and learn. And don't forget kind of what your point is, Melinda. Let's not forget what we've been through. I mean, I remember banking industries went through some really tough times, and I'm constantly reminding my team, we're not going to forget, we're not going to make some of those same mistakes, and constantly do our best to listen and learn and continue to evolve and grow. And so I challenge all of you in the health systems to do the same. I wish we could keep talking forever, but Michael's face has appeared for a reason, because it's probably time for us to kind of wrap it up. And there's lots of comments out there about whether health systems should own insurance companies, a lot of specific conversations about how can we make it easier for the patient, for contract adjustment. I mean, I wish we could talk all day and answer all of these specific questions. So maybe, Michael, we might have to do a health initiative part 2.
I think every year we're going to have to do this at least once a year, maybe twice or 3 times. And certainly you all are very busy. And I just want to say, on behalf of all of the William & Mary community, thank you for what you're doing day in, day out. Dealing with health issues is not easy on all of your shoulders, and the administrative roles that you're playing certainly is making a difference in so many thousands of citizens of Virginia's lives. And so thank you for that. And for the collaborative and innovative outlook. And I think we have a lot of work cut out for us, and hopefully the William & Mary community, just like you all, the rising graduates and existing alumni, will be there to support each other and help each other on the challenges that we face, including our new secretary that we just mentioned. So with that, I just want to thank Melinda, David, Kevin, and Alexis. Thank you again for supporting this. I will leave with a couple of things just to say that William & Mary is celebrating its birthday next week, 329 years old. So hopefully some of you will be in Williamsburg. I'll be driving down to participate on the 11th at 4 o'clock, I believe, is the program. And I believe you can also chime in virtually if you can't make it to Williamsburg. But also Professionals Week is this month. It starts on February 28th, and we've been promoting that. And we have some terrific panels. If you enjoyed today's topic, whether you're in health or interested in the topic, I promise you the theme of rethinking your relationship with work will be of interest to you. We have a great HR panel, also a panel focused on building community in the workplace, as well as great networking and redesigning your career path. So I hope that you'll join us February 28th through March 4th. Every day there's an event. And with that, thank you all again for your time. And it's never a slow day for you all. So I hope you have a quietish afternoon on a Friday afternoon, but I know you have a busy day. So have a great weekend, stay well. And
hey,
thanks
Michael,
again.
just
Yes.
before you end, I just wanted to, maybe we could follow up with some of these additional questions by sending them to the particular panelist, and maybe they can respond. I don't want people not to feel heard. So that may be something we could do that, you know, as a follow-up to some of the specific, it looks like even some of them were ones that would require some research and then response later. So I would encourage you to do that, and encourage all the alumni to get involved in, so that we can then, you know, choose others to be involved in panelists before. And Town Bank is glad to be a part of this as we all work to enrich lives and serve others. So thank you guys for letting us be a part of this.
Love it, Alexis. And then I will certainly work with our panelists to make sure that the channels of communication stay continuous, and that we work on sharing great answers and solutions to these issues that we brought up today. So thank you
Awesome.
again
Thank you.
for supporting this, and for all of you sharing your expertise today. Thank you, and enjoy the rest of the day.
Take care.
Take care.